Greetings, everyone, and Happy New Year, and welcome to our 21st Town Hall conversation. Again, hard to believe we've had that many. We're coming up now on 2 years on the pandemic, and really, quite honestly, had planned, as we've been talking about, on transitioning all of these to a little bit of COVID and a lot of other great things. But I think there's a saying that man makes plans and God laughs, and as we've seen, obviously, we've been in a little bit of a challenging COVID time, although as I share some data with you, I think there's a lot of reason for hope and a lot of reason for things getting better. And so we are planning for next month to have our series really return to a little bit of COVID and a lot of other things, and we'll be talking about cardiology and heart health at that point in time. I want, as always, to thank all of our members of the Society for Leading Medicine. I'd like to thank Jeremy and Caroline Finkelstein and Catherine and George Masterson. And I'd like to thank Ashley Drews, who is in the background. Last time, I think it was, she took we gave her a little break, which she richly deserves. And she will be there fast and furiously answering your questions, of which I know there's a lot. And y'all have asked a lot of great probing questions, and Dr. Sostman and I will save some time at the end to go through that. And in fact, really today is all about COVID, and I think you're going to see a lot of very compelling data, and as always, I'm trying to share with you the most current, recent, data-driven approach to everything we do. As I kind of alluded to already, and it feels like, we just keep going through one year's door and the next year's door and the next, and being chased by COVID, unfortunately, and hopefully we're not going to see a 2023 quite to this degree, but if any of us are being honest, we don't know that. I mean, we think it'll still be here. I'm certainly hopeful it won't be here in the type of framework that it is today. When we look at where we are as a hospital system now, you can see we've peaked. That's good. This is, of course, our inpatient numbers. And as I'll share with you in a second, from an infection standpoint, the community's peaked significantly, but the hospitalization side, particularly this time, is really taking a long time to break and start declining in any rapid fashion, which has been challenging and frustrating, to be quite honest. When we look at the community, probably the most sort of immutable, just sort of constant measure when we have it has been wastewater. Really, there's two reasons why the virus quantity in wastewater will go up or down. One is more people infected, right? More people, having human waste that has the virus in it causes more in the wastewater. But also it can happen with, if I am sick and I have a higher viral load with a variant than a previous variant, and there's probably both things going on with this variant, but no question, as we all saw, particularly over the holidays, this just absolutely exploded in our area and infected a ton of people. So this is the greater Houston wastewater, and this is the trend line. You can see it started out at numbers that were below 100%. 100% is the level of virus that was experienced on July 6th, 2020, which was the peak of that first big surge we had after the small little first surge in the spring of 2020. You can see we got up about 18 times the amount of virus in wastewater. Again, I mean, that is what it is. And this was infecting people, left and right, as we saw. And the timing of that peak was the 27th of December. And I will note our highest test positive day ever was December 28th, and December 27th was barely behind that. Those were days where we saw, dramatic, ridiculous numbers of positive tests. But what you've seen since then is it's coming down, fairly rapidly. There's about a week lag, so this comes out usually on Monday from the previous Monday. So our most recent data now is, solid 10 days old, which is actually good news because it's probably going to come down even further. So this is a really good, indicator that we are in a much better place already, but we've got a little ways to go, and we're still 3x what our kind of level was before, kind of almost 4x of where we were, before we, really entered this surge. And so this is the dynamic ultimately, if you look at this curve versus what we've seen before for Methodist. This summer with Delta, if you kind of overlay the timing, we had the blue infections leading to the orange census, so ultimately the people who are in-house. And then now we have this gray line, which shot up, as you can see, far faster than the blue line did this summer, and at far higher levels. That's a 7-day average of testing. And then you see in the gold line the census. And so, as we were predicting, the census broke. In fact, probably the 20th of December, we were looking at dynamics in South Africa and saying, about the 15th-ish of January is when we think this will start to break. And indeed, from a hospital perspective, I think the first day we went down was the 12th. But here we are, 15 days later, and unfortunately, things haven't changed dramatically. We're down, off of a peak of just at 800 to 700, but that's hardly a dramatic decrease. And I'll show you the biggest dynamic that's been at play with that. This is a lot on this graph. The gold is every single day, but let's just focus on the blue line, which is a 7-day rolling average. So if you focus kind of about a quarter of the way over, and you see for a long period of time, it was pretty steady, right at about 40% of patients who got a test ended up getting admitted to the hospital. Before that, when we were not in a surge, because that was the summer surge, it was 50 to 60%, right? It kind of makes sense. During a non-surge, you don't get a lot of people, who have known exposures or feared exposures. You don't have people doing screening for family gatherings, all those things. And so people who come to us are probably sick, they're symptomatic, and oftentimes need admission. Came down during that surge and really was pretty steady until things slowed down this fall and kind of crept back up towards what we were seeing in the summer, in the late spring. And then it plummeted as Omicron came around. And we celebrated this. This was good news. Thank goodness, because our peak day was 1,100 or so infections positive. If we'd been at the 40% level, we would have admitted 400 people to our hospital at that point, which would have been nightmarish, as you can imagine. So thank goodness it did, but watch what's happened ever since then. It did that for about 2 weeks, and then right about the turn of the year, it's just steadily been creeping up. It's actually peaked at about 34%. It's about 33.5% right now, so it's not dramatically better than with Delta. It's still lower. And I think, we've looked at a lot of the reasons, but when we look at the age distribution of patients coming to us, it's just gotten older and older and older. You can watch a 25 to 40-year-old band of patients just march down by week, and then you watch an 80-plus-year-old group of patients march up by week in terms of the proportion. So really what we had was, a bunch of people who not illogically were, not being all that cautious at the end, at a Delta time where things were pretty steady. Getting infected first, but unfortunately starting to infect the more vulnerable, the older, and because of that, we're now seeing, really sticky hospitalization numbers as we've talked about. Now, one definite difference this time is we do see incidental admissions. We'd see an occasional incidental admission in previous surges, but very few. This time as high as, in the 30s to maybe even as high as 40% at earlier parts. Right now, actually, that's kind of moved down because we're seeing kind of older people. Length of stay has been creeping up. A lot of things are resulting in that census that just won't go down. And one thing to remind you, and it's a pretty good article, I kind of hate the headline because it, like the press so many times, it's a little sensationalist, but the actual content of the article is pretty good, and it talks about the experience at some other institutions, kind of in that 30, 40, even as high as 50% in some reports, but it makes the very good point that, look, even during the flu season, we'll get people with colds, flu, mild flu sometimes, but it tips over chronic illness, and so that line of what's incidental versus not incidental is a challenge. But the reality is, if you're a hospital system and you're a healthcare worker and you have all the PPE in place and everything else, every one of those patients to some degree certainly stresses the system. Less so, of course, than if we had every single one of these patients, be directly for COVID pneumonia. And so that's a tiny silver lining in all of this. The other piece is most definitely, and I had asked this question the last time we were talking of, what do we know about this? Is it less severe? And the answer was probably, I think most definitely it is on average less severe. So many more people will get the infection because it's much more infectious. And the average person has far less risk right now than they did before. But on aggregate numbers, that can kind of catch up with you. And I want to caution, I'm not going to lead you through this, but when you get a bunch of reinfections like we're having now, whether it's a breakthrough infection or a reinfection, when you get a lot of that, you can sometimes misinterpret some of the data. And so it's probably not quite as mild as it looks like on the surface, but it is most definitely milder than the previous variants, which thank goodness, as I said, or we really would have been overwhelmed this time. I'm very proud of our team. Dr. Musser and team, consistently have excelled during this. And one of the things they did very early, this was released in its first form about the 20th or so of December, because we sequence every virus that comes through. We've now done well over 70,000. We were essentially the first paper I saw that started in the US that started to say, what do things look like? And we saw a number of key factors here in terms of the difference with this infection versus previous ones. Now, that was the 20th of December, and then what they've done is they've added each week. And so we've actually seen some of the shifts that I was talking about. Let me just show you just a little bit of the data here. This is now more recent, so earlier we saw bigger differences, and some of them have started to narrow. But nonetheless, take a look at a few things. First off, large number of patients now, as you see, 4,500 or so Omicron compared with about 3,000 of the Delta that they were doing this analysis. There's a bunch of matching that happens to try and make sure your kind of risk factors and others for the individuals are consistent. When you look at the median age, it is about 6 years younger than Delta. And remember, Delta was a median age far younger than previous infections. So keep in mind, when you get younger people, you get better outcomes. So that's some noise in the outcomes. But nonetheless, length of stay, 3.2 versus 5.1. All the different ventilation numbers are better. Mortality is far better, keeping in mind that that's a lagging indicator, so that may change. And very importantly this time, what we saw was lots of breakthrough infections, as we all know. What we're seeing is the vaccines, particularly if you haven't been boosted, and I'll show you some data, we're seeing breakthrough infections. Now remember, this is everybody tested, not everybody hospitalized. We're not seeing dramatic numbers of breakthrough hospitalizations quite to the same number as we see infections. But back in Delta, 97% of these individuals, as you see, were not vaccinated, and now you can see we have a significant number of people who are vaccinated in the mix as well, which has been one of the challenges with Omicron. Not too long after that, about 10 days after that first came out, we saw kind of the first large-scale population-based study. This was actually out of Kaiser Permanente in Southern California, working with UCSF, who did the analytics. And I'll call your attention to a couple things. They looked at this big population. In the upper left, you see the distribution of length of stay. So what you see is that big, quick peak. So early on, people in and out, in and out, in and out. Now, one thing, if you think about hospitals, the hardest day for a nurse, the busiest day for a nurse is the admission day or the discharge day. And so we always try to balance that load. So while, we had lower census, we had, kind of a churning wheel that was very difficult from a nursing perspective to manage. But what we saw then also in purple and green on the left, you see all the different metrics, whether, it's ventilation, mortality, et cetera, et cetera. And in each case, you see in the green that we're doing much better with Omicron. And so the risk ratios for outcomes, are definitely lower with Omicron. And now, literally hot off the presses this Wednesday, we have a very large CDC look at this. This is a graph of people who have been infected. What you see in the dark, the solid blue line is the number of cases, okay? What you see in the dashed line is you see all of the emergency room visits that are there with a discharge diagnosis of COVID. And then you can see in the smaller dash, the uptick in admissions right now. I want to call the point out, if you look at the United States then, in Omicron, we have far more people in hospital now with COVID, Omicron, than we did with Delta. And I'm pointing that out now because we're going to talk at length about that in a couple of minutes. When we looked at this, again, now you see 250,000 cases they looked at last winter, 164,000 cases they looked at that we were having as an average, 7-day average in Delta, and then 798, almost 800,000. So right there you see that on a population basis, dramatically higher numbers of people getting infected. So you can see up 200%, up almost 400%, depending who you're comparing to. Then you look at how many admissions, and what you again see now is hospitalizations are 75% higher in the United States right now than they were during Delta. So when you think about it's milder, but the numbers catching up with us, and we'll look at that in just a second. You can see the deaths, this is again not per person, this is now the number of deaths reported in the country, are back up to this summer's level. In fact, some of the most recent days are even past that. What we see is the stress on hospitals is the highest, 12.9% of beds. Thankfully, we see lower ICU admission. We see lower in-hospital death rates and different numbers in hours, but lower length of stay. So once again, kind of our people got out in front, got the things reported, and then as we aggregated data, very consistent with what we saw. So let me show you what's happened to hospitals. And the Wall Street Journal did a very good analysis about 10 days ago of this. And they said, look, you can now look at some of the studies I just reviewed with you. And what you saw was for 10,000 people, you'd have symptomatic hospitalization. So they differed between incidental of 110 with Delta, only 16 with Omicron as you looked at that. So obviously that's a good thing. However, when you look at where the peaking daily new cases are, in fact, now it's even higher, or it has been higher in some of the period before, now it's starting to peak, that math kills you, and that math ends up resulting in far higher. And so if you remember what I was saying in early December when we had a meeting, I was saying, look, the thing I worry about is just the large numbers catching up with everybody, and that's indeed what we've seen. The other major difference this time is, the pressure on staffing. Of course, with breakthrough infections, staff getting sick. Now, the good news is they got sick, but they didn't get really sick. So we had, probably 3,500 staff, and we have 28,000 people, but we had about 35,000 get infected. Almost all of those are a breakthrough infection since we have a mandate. Only one out of 3,500 people ended up sick enough to be hospitalized, and that individual did well and went home, never needed anything past acute care. So the vaccines, real world example with us, that they are protecting people from severe illness. But look at the spike we saw in new leaves of absence that happened right at the end of the year. Dramatic. Now the good news, it came down pretty quickly. Now, some of that is no question that the virus is doing less in the community. Some of that also, remember, the CDC changed its guidelines, and so we started being able to bring people back to work a little earlier. We also made a couple benefit changes that had been pre-planned for December 31st that are in there as well. But nonetheless, a lot of stress on our folks. And in fact, again, very, very tiring, exhausting, challenging for individuals, particularly the front line health workers who are working. So, one of the stories and articles that kind of, gave me some strength and comfort, and that I've relayed many times, and many of you will know this story. But Admiral Jim Stockdale, who was the highest ranking American officer who was held prisoner for about 7.5 years, I believe it was, in the Hanoi Hilton, was asked, well, who does the best and who does the worst in a situation like that? And he says, the worst were the optimists, the pure optimists, the people who said, by this Easter, by this summer, by the 4th of July, by Christmas time, we're going to be out of here. And every time their hopes were crushed and their hopes were dashed. And he says, the people who did the best, his attitude was, I always had faith I would get out, I would succeed, I would be okay, I would return home to my family, but I had I focused on the cold, hard realities that I faced right there in my current situation. And I think that's the situation we're all in, and I think that's the situation healthcare institutions are in as well. We can't predict exactly, obviously, where things will go, but we have to face the reality on the ground, knowing this will ultimately pass and we will get past this, but we just don't know exactly when that is. Now, one of the things that's been really unfortunate is we are again seeing a big uptick in deaths, and you saw that data in the United States, not quite at levels that from the U.S. wide that we saw this summer, but actually, or last year rather, back to kind of this summer. When you see ours, here in orange you see the 7-day admissions, so this is kind of the people coming in, of course, who are in the denominator of who might get ill enough to sadly pass away. In blue, you see then a 7-day rolling average of deaths. And so we bubbled along for a while during this surge, and then, it started hitting, as you see, and notice kind of the relatively typical time lag after we see the surge in infections. Thankfully, it's not gone up as steep. We are seeing lower mortality, I think, without a doubt, as you saw in all those studies. But, let's not discount it as no mortality either. We hit 10 per day, 10.5 per day. We're back down to about 8 right now. This is a significant amount of death, and that sadly has been the story around the world, but especially in the United States. This is a comparison throughout the pandemic of a number of large countries. Brazil, who has the record of any large country in the world, although you can see has flattened significantly, and then us versus a lot of kind of first world economies, as you see that there. And unfortunately, the United States leads the way. I want you to specifically look at the UK. If you look at up until kind of about a year ago, the UK actually had far more deaths than the United States had. They had really had significant death kind of rising in the fall and early winter. Once vaccines came in, look what the UK's curve does. It was flat for the better part of last year. It's come up in the latter part of the year when they did ease a lot of restrictions, as you recall, in mid-July. But I'm going to spend a lot of time now talking about that because we surged past them, and the slope we're on right now is dramatically different than the experience they're having both pre-Omicron and during Omicron. So let's just look at that real quickly. If you look at the upper left here, this is cases per million for both the US and the UK. I mean, you'll see some timing differences, right? They have tended to have their surges before us. Of course, they led the way on the Delta, and they didn't come down quite as much as we did on the Delta surge. But notice Omicron, almost exactly the same experience, slightly delayed, but in terms of how many cases per million that they're seeing. I'll talk about testing in a little bit later as a caveat on that. But look at the difference on the right. Blue line is US, the redder line is UK. Way, way, way more hospital admissions this time for us, and actually way, way more hospital admissions kind of throughout the better part of this year. And it's not just hospital admissions to say, well, are we treating people particularly differently? Look, our standards to admit or not admit. Look at ICU utilization, which is sick people. Dramatic differences between us. And so if you get to the bottom line on the bottom right, by and large, that red line for them has decoupled pretty significantly in terms of death versus the infections. Now, it has gone up during Omicron, but it has decoupled for most of that time, including compared to us, with Omicron, because look what happened to all the death that's happened. It never really came down post-Delta, has gone up with Omicron. We're still seeing, they're at maybe 55-60% of the death we're seeing with the same kind of Omicron peak. And so we're having a very dramatically different experience than the UK. And you have to ask yourself, okay, why is that? We're actually pretty similar countries. If you were to pick, a few countries around the world and use a bunch of metrics and say which are most similar to us, they'll make the top 3 or 4 or 5 every single time on just about any metric that you look at. So there's not like an obvious reason you would say. So spent a lot of time thinking about, okay, what are possible reasons for this? Now, let me start by saying this is not an exhaustive list. I can come up with a lot of other detailed issues. I'm sure there are things I'm not thinking about, but I think I caught most of the big categories. And one that's not on here, honestly, is just bad luck. And that's always possible, right? I mean, particularly when you look at kind of the dynamics of spreading an epidemic and a pandemic. But here's some of the possibilities as you go through. Maybe we're far older on average than the UK. We know older people have died more and they've done more poorly. Maybe there's an age distribution. Maybe we're sicker than they are. Maybe we have underlying differences in our health status. Maybe our health system just isn't very good when you actually get to the hospitals versus, in the UK. I'm not talking structural access. I'll get to that in a second. Maybe we have different kind of social support, different poverty levels, different access to healthcare levels. Maybe there's a difference in the virus. Maybe we've seen different variants, it's behaved differently, et cetera, et cetera. Maybe socially we've acted differently, and at times we probably have, but we'll talk about that in a second. And finally, the last two, are we testing differently? Have we done different things around contact tracing? And finally, are we using vaccines differently? So I'm going to go through each of these, kind of bring you as best I can data, give you a little bit of opinion in there as well. I'm sure everything creeps in to some degree, but I've kind of tried to score these as, I think this is a reasonably big factor, or I think it's a small factor. So here's age distribution. So if you look in the gray area at the top, it's over the last decade or so, you'll see the proportion of the population that's older than 65 years old. So what you actually see is in the UK, they're older than in the US. So it's actually backwards for a hypothesis of why we might do worse than them. So it's not this. This one I can feel really confident. I think age distribution really has nothing to do with this. In fact, it would have handicapped them a little bit. So maybe it has something to do with how sick we are. Well, if you look across developed countries, we have the highest burden of chronic disease. This is defined by people who self-report 2 or more illnesses on a specific list of illnesses. When they do, they call them avoidable deaths, or they actually say amenable deaths. So deaths that are amenable to being prevented by healthcare treatment. In the light blue, you see about 20 years ago, but in the dark blue, you see more recently. So everybody's gotten better, but you can see the U.S. has the most, at the highest rate of what are considered amenable or avoidable deaths. And then if you look at obesity, we have a significantly increased proportion of individuals that have a body mass index of over 30. And what we have seen very consistently, really at all ages, when I talk to my wife, a lot of the teenagers they see, if they're not, immunocompromised or something else, they're obese, and they would hit these metrics. And so 40% of our population has a BMI of over 30. And so I think there's something here. I think our general health in the United States is probably not as good, or certainly we probably have some vulnerable bands of the population with obesity, with some chronic illness and others at a higher rate than they do. So there's, I think, most certainly some explanation of this here. It's really hard to measure the quality of health systems, right? What you ultimately want to know is, hey, if I got this type of cancer, do I do better in the UK? Do I do better in the US? If I have heart disease, all those kinds of things. I'm not talking about population-based, but I'm talking about once you're sick. It's really tough to find great data for the UK. There's pretty recent data, very recent data from the CDC that's pretty solid. So I think these are approximately the same, again, with the caveat being it's hard to really pin this down. Of course, none of this, if you were looking at it, that you can find out there, would actually population adjust, risk adjust, age adjust, all the different things between the US and the UK. So we're probably in the ballpark here. There may be a little piece of this there, but I don't think there's a major factor on aggregate across all of the medical system in each of the countries. But let's look at access. So the UK, if you remember, has nationalized health. It has its good parts and its bad parts, but one of its good parts is everybody has it. So you have 100% over the last 10 years of people who have access to healthcare. In the United States, we started out kind of in about the 84% range in 2010, and then with the Affordable Care Act and a number of other things, came up pretty significantly, have dwindled off the last couple of years for a variety of reasons. But the bottom line is we still have over 10% of the population, or about 10% of the population in the U.S. without insurance, without clear-cut access to easy-to-find healthcare. Now, that doesn't count safety nets, and there are some other things there, but clearly we've seen access as an issue. And we have higher poverty rates and a higher gap for people who have poverty in the United States and the UK. So there's probably something here as well in terms of access to healthcare. If you look at the variant, this is the distribution of the variants by country. On the left, you see the UK. On the right, you see the US. So, we had a little more variation in what we saw kind of earlier on. But really what we're talking about now is the divergence that's happened over the last year between the US and the UK during that time. And it's pretty much exactly the same. Everybody had a bunch of Delta, and then everybody had a bunch of Omicron. And so I don't see a difference in at least the distribution of variants that would describe this, other than they've tended to get it a little bit before us. Is there a difference in social behaviors? Pretty hard to measure. But I think the UK, as we see, I like soccer. I watch a lot of soccer games. It's no different watching an EPL game than watching an NFL game. Nobody's masked. They've pretty much moved on, and they did back in July. Before that, they were probably more stringent than us. You can see that. So if anything, by a stringency index, keep in mind this isn't a perfect index, but by this stringency index, if anything, we've been a little more locked down as a country than they have. Not in Houston, for sure. But remember, some parts of our country have been pretty extreme in what they've decided to do. So there's probably not a meaningful difference in how we've acted socially. So what about testing? This is a population normalized testing number. Notice early on we pretty much were testing at the same rate, and then they just started blowing us out of the water in terms of the amount of testing they're doing. Now, we've all seen it during the holidays. Many of us used it. There are effective testing strategies that can keep people safe. So there's something here. Now, interestingly, right, one question then is if they're doing that much more testing, are they finding more mild disease or more asymptomatic disease? And is some of the mortality rate decrease we're seeing there versus infections just because they're catching more infections? What that would imply actually is if we had a perfect testing system of every human being in the UK and the US, that we actually have way more infections than they do. But they look like they have the same amount of, there may be something there with that. But I think there's also probably something there with strategies. Everybody there has gotten free tests for a long time. They get them quickly, they use them as a strategy. The other interesting thing they've done is a lot more contact tracing than us, really hard to measure. Here's an article from Nature. It's a little dated, but it nonetheless made the point that they could show evidence that contact tracing was working. So I think there's a difference here as well. I mean, we've done essentially no organized contact tracing in most of our country, some pockets of that, and of course testing has been pretty hard to find. I thought this was a pretty funny cartoon, pretty much described the Omicron surge during the holidays when good luck finding a home test, even though everybody wanted to get one in the United States. So that finally brings us to vaccinations. So this is the vaccination rate to be quote unquote fully vaccinated, 2 doses in each of the countries. And what you see is the US jumped out. Actually, we were faster than they were. Now they had a different strategy, if you remember. They actually worked to get 1 dose to everybody before they got 2. So there's probably a little noise in that early on. But for now, the better part of months and months and months here, the better part of a year even, we've diverged pretty substantially in terms of the percentage of the population that is now fully vaccinated with 2 doses. It's worse when you look at boosters. So the UK has done a really good job at boosters. If you look at the entire population, including a bunch of kids who are not eligible for boosters, they're at about 50%. And I'll show you data later. If you look at everybody 18 and up, they're in the mid-60s. And the US is far, far, far below those numbers. So, to then postulate that, okay, that may have something to do with it, we have to understand, do we think vaccines are working during Omicron? And there's actually a really good CDC study, very recent now, multi-state analysis, looked at a couple 100,000 people who went to an emergency room or an urgent care center, about 90,000, just under 90,000 people who were hospitalized. Darker blue is Delta, lighter blue is Omicron. So let's look at the left. The left is mRNA vaccines. So they only looked at Pfizer and Moderna from August to January. And they looked at how effective are those against preventing infection. So against Delta, people who had gotten 2 doses within the last 179 days, very high, 86% effectiveness. They saw some decline down into the 70s for people who are more than 180. This is the whole reason for starting to talk about boosters. And then you got it all the way up to 94% with a booster. So very effective against Delta. But of course, Omicron, we've seen a lot more breakthroughs. So everything's lower with Omicron. If you were within 180 days, you saw about 50% effectiveness against preventing infection. Less than half if you had waited more than 180 days. That's a lot of people. But look what you were able to do with a booster. You got up to 82% effectiveness. It ain't perfect. Some people are still going to have breakthroughs. Quite a few people are still going to have breakthroughs. But still, significant protection. But again, what really matters is, can we prevent hospitalizations and then, of course, the death that follows sometimes for some people. And again, you see higher numbers each time with Delta. And you see, down to about 57% effectiveness if you've waited more than 180 days. So some of that protection is waning, and that's one of the many reasons we see a number of vaccinated people in the hospital. But look again, 90% effectiveness. It's not perfect, but that's pretty darn good effectiveness. How durable that is, we don't know right now, but nonetheless, pretty strong evidence that these are working. A second CDC study came out, and you can see the trend line of cases, and the upper line, that's the solid line, is people who are unvaccinated. The dashed line below, the main dashed line there is people who are quote unquote fully vaccinated, and then you actually can, under that, make out some booster stuff. Don't pay too much attention to that. Just pay attention to the fact that there's consistently been a large gap between vaccinated and unvaccinated. Unfortunately, both going up during Omicron, but still going up at very different levels. There's still a big difference. And when you look at death, it's even much more profoundly different. And you can see, usually in the 15 to 20 times the risk of death for people in an unvaccinated group versus a vaccinated group. And now remember, they're not differentiating unvaccinated prior infected versus unvaccinated not prior infected. So this is all comers unvaccinated. So I would guess that some of those unvaccinated never prior infected are probably even higher risk factor than that, than some who might have had prior infection in there. We don't have the statistical reporting for the deaths yet in December. You can obviously look at the trend line there. That's basically some lag time issues, but I think it's very strongly suggestive. Switzerland does a great job at kind of very real-time analysis of who's who. Look at the death rate, including now in Omicron, where they saw a surge of death in the unvaccinated versus the fully vaccinated versus the fully vaccinated with a booster. So even if you don't get a booster, you're well protected against death, but you're even more protected with a booster. So the answer is yes, the boosters work, the vaccines work. And so when you look at those differences between the UK and the US, it's very real. And so I went to the source data from the NHS and the source data from the CDC. And I couldn't get one piece of the snapshot from the US in the middle there, but let me walk you through this. So in dark blue, that's if you've had 1 dose. In the next light blue, that's 2 doses. In green, that's 3 doses. So on the left, the entire population over 18 years old. In the UK, let's just focus on fully vaccinated or boosted. 87.8% of the entire population over 18 has received 2 doses. We're at 73%. But focus now on the dark blue line with me. They barely had any attrition. We had marked attrition there. This is a national conversation about vaccines, a national conversation about safety of vaccines. It's very organized anti-vaccine efforts. It's disseminated information that's incorrect, et cetera, that unfortunately have bled into our population. That is a massive missed opportunity, 14% of the population difference in an 18-year-old age band. And then look at the difference again, 18 and up with boosters, dramatically different. But you can see the difference in 50-year-old. Most death has happened in 50 and plus, and of course most has happened 65 and plus. All I can really delve out of the data is, a 87 to 54, dramatic difference. But look even at the older population, the really high-risk population. Not massive differences on fully vaccinated, although, don't sneeze at 7 to 8%, of very high-risk people who've been most of the people who've been dying during that. But look at the marked difference. I mean, a 30-point difference just about in boosters. So there is no doubt to me that vaccination is a big part. In fact, I believe it is the biggest part, but I think there are multiple other factors. And so little funny cartoon handing off Delta to Omicron this year. But as you look at this, my conclusion, why is the US in such worse shape than the UK from the decoupling? It's a complex issue, underlying health of the population. Most certainly, obesity is a big player in that. Access, testing, contact tracing, and especially vaccine uptake. A lot of those are not in our short-term direct control, but a couple of them are. Getting boosted, getting vaccinated are very much in our short-term control. Enhancing availability of testing, utilization of testing are still within our short-term control. So I just want to point out a couple last things. One is, as we continue to have lots of discussions about vaccines, and there'll be lots of Q&A about that. I'm very proud of our team. I'm very proud of Dirk and what everybody's done. We've always done our best to stay apolitical, stay very data-driven. This is a screenshot from a town hall on June 11th of 2020. So 6 months before the vaccines came out. Look at what Dirk had up there, what he was reviewing with you. Is it safe? Does it cause, antibody immunity, cellular immunity, et cetera, et cetera? Started with, is it safe? And then it ended with, will people take it? And of course, that's been our big, big challenge. And so we've been very consistent. As you may have seen, we chose to mandate a booster for our employees based on all this data. Our scientific and medical committee made that recommendation to me. Every one of our medical staffs have followed. There's one that has its meeting in a day or so. We'll follow with that. But 7 of 8 have already gone through and have followed with that for all of our medical staff. The 8th will go later this week. This is because we need to protect the patients who are here. We need to protect our staff. And we have an obligation and duty to keep our staff well and on site to care for people with all disease. And as you see, that was a challenge this past time. If I knew everything I knew today, we would have mandated boosters in probably the October timeframe, we didn't know everything we did. Our scientific medical committee talked about it, did not feel the data was there to support it yet, hadn't seen all of the safety data, the effectiveness data, et cetera, et cetera. And, but I think we'd all say right now we could have prevented a lot of absenteeism and other issues during this last surge had we done this earlier. So we are now moving forward. As you probably saw, we actually synchronized with Baylor College of Medicine and Texas Children's. I'm very grateful to each of them for working with us on that moving forward. And with that, please go get a booster. If you haven't gotten a booster, I hope we've convinced you with the data that it is the right thing to do. If you haven't gotten vaccinated, please get vaccinated. I will say, at this point, I think very few people are entering the vaccination pathway, but there's a lot of people who chose to get dose 1 and 2 who've not gotten dose 3 yet. And now is the time to get it. Get yourself better protected. Kind of complete the deal for now. We'll talk later about, am I going to need other boosters? Am I going to need annual shots? Probably yes, but probably not for a while, we hope. But with all of that, I'll wrap things up and I'll turn things over to Dirk.
I'm going to go over some of the same stuff, and that portion I'll go over rapidly, and then a bit different. So vaccine updates, Mark's covered some of this, so let's just ground ourselves on what we knew about the vaccines before Omicron. We knew that they were effective against infection for 4 to 6 months. They reduced transmission, even with Delta. But as time passed, they offered less and less protection against infection as the normal waning of circulating antibodies took place. And we know that your antibody levels correlate, at least on a population basis, with protection against infection. Unfortunately, we do not yet know a sort of cutoff safe value for an individual. So it's very frustrating, but we just don't yet. We know that vaccination protects you against severe disease like hospitalization or death for a longer time than it protects you against infection. Likely this is related to cellular immunity. We don't know how much longer lasting this is going to be, but it seems to be holding up pretty well. And we know that a third booster dose of vaccine restores your antibody levels and restores protection from infection, and of course continues the protection against severe disease. What we don't know yet is the natural waning of antibody levels. Is that going to be slower after a third dose than it was after the first 2 doses, or is the time course going to be the same? I think what we're starting to see is that it's going to wane pretty much at the same rate, but stay tuned on that one. And then prior infection, which has been, I think, more in the news lately, but has always been a question. And in fact, that we've talked about this at these town halls for at least 7 or 8 months, if not longer. What we knew from the pre-Omicron data was that prior infection was about 80 to maybe 85% effective against infection. The data was lower quality data than for vaccines, just because it was very hard to tell, when people got infected, how severe their infection was, and so forth. So very, very hard to do what you call a dose response curve. We did know that it was less effective in older people or people with milder infections. And we've known for quite a while that a prior infection appears to be synergistic in protecting you with vaccination. So if you have prior infection and vaccination, that seems to be not exactly super immunity, which is, I think, what some people are billing it as, but certainly a kind of broader, possibly deeper immunity. Okay, we're going to switch to Omicron now. Everything I'm going to say from this point forward is all about Omicron. So here's some data from the UK showing in the black squares Delta and the gray circles Omicron. The protection against an infection with time The bottom scale is weeks after your vaccination. And you can see that Omicron starts out being a harder nut to crack, and the protection against Omicron wanes more rapidly than the protection against Delta. You can see with a booster, and this is all data with people who've gotten initially vaccinated with Pfizer and then get either a Pfizer or a Moderna booster. You can see with the booster that the protection against infection shoots back up with either of those, and then it starts to wane. You know, maybe in this data series a little more slowly than the original, but it starts to wane. It seems like the Moderna booster on top of the Pfizer vaccination seems to be a little bit more durable. But in truth, the time that we have been observing this is really not long enough to say much conclusively. But, you know, vaccine wanes, worse against Omicron, boosters restore it. You know, there's data and data and data on this, but that's the basic case for boosters. Here's data from the CDC, and you won't find this table anywhere because it's sort of a pastiche of different data sets. But with before Delta, during the Delta surge, and during the Omicron surge, what's the hazard ratio for getting infected if you've had 2 doses of vaccine versus not being vaccinated? And you can see that the vaccines were much more protective before Delta, less protective during Delta, and least protective during Omicron. We've known this for a long time. What you will see in the bottom row in the middle column is that you give a booster and the hazard ratio for infection goes right back to where it was for full vaccination before Delta. You'll also see that the hazard ratio for death without a booster, with 2 doses of vaccine but no booster, compared to unvaccinated, is very stable regardless of the variant you're talking about. And that is most likely because the antigens on the virus that your cell-mediated immunity responds to are much more stable, less mutable, less changeable than the antigens on the spike protein that the antibodies go after. But the booster clearly helps to overcome antibody resistance and protects against infection. Here's some actual serology data that pretty much tells you the same thing. Panel A shows the neutralizing antibodies against the original in black and Omicron in red. A few weeks after your second dose of vaccine, you have very little antibody neutralization. In panel B, if you wait 8 or 9 months, the situation gets even worse. You have waning of antibodies against the original vaccine, the original virus, but there still are, a reasonable level. And against Omicron, you're basically 0 antibodies that neutralize the virus. Panel C in the bottom left, you give a booster, and you have very, very good antibody levels. And panel D, 4 months later, which is about as far as the data goes, there's still pretty good antibody levels against Omicron. So again, maybe some tantalizing data that after a booster your antibody levels do not wane as rapidly, but too early to tell for sure. And this is just another look at that Swiss data that Marc showed. Unvaccinated versus vaccinated with no booster versus vaccinated and boosted. Vaccination saves lives. It's as simple as that, and the booster saves even more. So there's some recent data that absolutely fascinating about prior infection and how that interacts with protection from infection and how it interacts and compares with vaccination. This is data from the CDC. It's a much bigger data set than this. I've cherry-picked just a few numbers. And if you look at the top row, that's back in the summertime, and then the bottom row is more recently this winter. And then it's looking at the hazard ratio of getting infected if you're unvaccinated and no prior infection versus fully vaccinated. You see you're 20-fold protected back in the summer if you're vaccinated and you've not had a previous infection. It goes down to 7-fold more recently. Combination of waning antibodies and more variants. Because remember, the vaccines are predicated and patterned on the variant that arose in Wuhan, China in November of 2019. Those are the same vaccines. So as the variants change and become more resistant to vaccines, the protection you get is clearly going down. Middle column is unvaccinated people who have had a prior infection. And you can see back against the original strain, the vaccines blew prior infection away as a way of protecting yourself. But there was some combination of vaccination and prior infection that helped you. Now, at this point, I have to anybody who wants to delve into this really needs to actually read this report. And the CDC is very careful to say that there are at least 7 pitfalls and biases that this observational data is prone to. But I think the effect sizes here are big, and so we're seeing something real. So if you look at the bottom row, vaccinated without prior infection seems to be less protective than actually prior infection. And vaccination plus prior infection seems to be the best. There's a lot of scientific data about the response of the immune system to infection, to vaccination, and I think it's fair to say that we don't understand everything that's going on here. But we will come back to some of these thoughts when we talk about vaccine strategies going forward. So where are we now? For people with immune compromise, people who are at high risk, they should absolutely have a 3-shot primary vaccine series and a 4th shot maybe 6 months later. I don't think anybody would disagree with that. But what about the majority of people who are at quote-unquote ordinary risk? All we have to offer for vaccination now is just repeated doses of the original vaccine. And I think at some point, hammering away at different viruses with the original vaccine is going to, there's going to be diminishing returns here. I think that makes sense. A 3rd shot as a booster at 4 to 6 months, I mean, Marc has showed you data, I've showed you a little bit of data. It's supported by the data. And very importantly, the safety data, which we haven't showed you, indicates that reactions against a 3rd shot are actually lower than against a 2nd shot or a 1st shot. So it's effective, it's safe. In my opinion, there is no reason not to do it. 4th shot, 4 to 6 months after a 3rd shot, you could argue that, it'll boost your antibody levels, probably safe. No reason to think it's not going to be safe. The rationale is good, but there's really not very much data. The country that's kind of in the lead here, as it has been all along, is the country of Israel. They are now recommending a 4th shot for everybody over the age of 18, 5 months after the 3rd shot. They've shown that it again increases your antibody levels. In older people, there's some early data suggesting protection against infection and severe disease compared to only having a third shot. But I would have to say this is very early, very preliminary data. Now, some people, including even somebody from the European Medicines Agency, who probably got his hand slapped by his colleagues for, talking nonsense, have said, well, if you keep getting these boosters, you're going to get immune exhaustion. So immune exhaustion is something that is seen in like AIDS or hepatitis C, where your immune system is constantly exposed to an antigen or a virus for a period of months or years. It's really not the situation with periodic booster shots, and there's been absolutely no evidence for this in practice. But I think you have to assume that, like I said, just hammering away at a different virus with the same vaccine is going to run out of room at some point. Now, some people have used a fourth shot to cover a specific, I'm going to do, intercontinental travel. So I'm going to get another shot to boost my antibody levels and cover myself for that specific episode of increased risk. There's actually no data to support doing this, but some people have done it. In the future, I think we're going to see tailored boosters. My guess would be the trials of the Omicron-specific vaccine are going to show that we ought to be changing to that. And then we have new approaches that are really going to be the solution, but are 1 to 5 years away from being available in practice, and that would be mucosal vaccines or these pan-coronavirus vaccines. I don't have time to talk about them, but you can download the slides and you can read these articles yourself if you'd like. Early treatment, critical part of the pandemic response. The changes in the virus have really played the hob with the monoclonal antibodies. Because they are so precise, they're most sensitive to immune evasion. But we do have one that works for pre-exposure prophylaxis for high-risk people. That's the Evishield. And we have one for post-exposure prophylaxis, early treatment. That's sotrovimab. We do still have monoclonals that are effective. The problem with monoclonals is also that it takes a long time to make them. It's a very complicated process. So it's going to be a while to spool up to have, coverage of the population. We've got COVID pills now. Our national anthem, isn't there a pill for that? We do have them, especially the Pfizer pill appears to be really good. The Merck pill has kind of been a little disappointing. And also we have a drug infusion, that's good old remdesivir, that has shown if you give it early, is very effective at reducing hospitalization. So the problem here with the monoclonals and the antivirals is really one of supply. It's a temporary problem. Testing, Mark talked about this. And the thesis here is that with home antigen testing or home nucleic acid amplification testing, they may not be the most sensitive tests, but they're actually very good at finding when people have a high load of virus and can potentially be at their most infectious. So, this again is something we really ought to be doing. Here's some data from San Francisco. At a walk-up testing site, they did PCR on everybody who had antigen testing. And they found they're pretty darn accurate, even for people who are asymptomatic. The higher the load of the virus, the more accurate the antigen test is, and the more infectious you are. No problem with different ages. They perform similarly regardless of whether you're vaccinated or not. And the false positive rate was very low. So a good vote of confidence for these antigen tests. How do they relate to, isolation and quarantine? Well, here's a top study here from Hay. Is actually 204 NBA players who were tested every day. Those who got breakthrough infections with Omicron and Delta, they were really lasted pretty much the same length of time. But a lot of variation. Some people cleared the virus rapidly, others cleared it more slowly. And at day 5, 50% still had high loads of virus, meaning they probably were infectious. So here's where, I would really differ from the original CDC guidance that you could stop quarantining at day 5 without testing. Again, at the UK, they looked at viral loads after 7 days of isolation. And they found that not using an antigen test to clear yourself to rejoin society, there was still a 1 in 6 chance of being infected, which was reduced to 1 in 10 if you had a negative antigen test. So the story here is get a hold of these tests and use them. I won't go through this in detail. Thank you, Dr. David Bernard. These are the antigen tests the Houston Methodist thinks are accurate and would recommend using. So finally, transitioning to endemic. This has been in the news a lot lately. Everybody thinks we're entering an endemic period. And you look at the data and you see, what are they seeing that I'm not seeing? Look at these peaks in South Africa. Look at the Houston Methodist hospitalization data. This sure looks like a pandemic to me. And I think the issue is that we're entering a transition period. And in fact, all pandemics end, but diseases rarely disappear. I mean, the Black Death in the 14th century in Europe killed half the population of Europe. It only lasted for 7 years. I'm sure it seemed like a really long 7 years to those people, but in the kind of course of history, that's not a long time. But diseases don't disappear. I mean, the plague still exists, and every now and then there's an outbreak. We are, I think, beginning to enter a transition phase between worldwide outbreaks and local outbreaks, but that doesn't mean that, it's time to party and this is the common cold yet. Look at malaria, look at tuberculosis. Those are endemic, but they kill a lot of people. We can absolutely expect variants of COVID to continue to appear. We're going to get, most of the world's population has not been fully vaccinated. It's clear that there are numerous animal hosts ranging from, the white-tailed deer to the household pets to, the tigers and lions in the zoo. It appears like this virus can jump from animals to people, back to animals, and back to people again. And that's a setup for continued variants. So let's compare what endemic COVID might look like to influenza, another endemic viral disease which occasionally becomes pandemic. Flu affects maybe 10% of our population a year. There's anywhere from 10 to 50,000 deaths a year. And as a society, we have basically implicitly decided that that's okay. We urge people to get their flu shots here at Houston Methodist. All of us are required to get our flu shots, but there's no vaccine passport for influenza shots. So as a society, we've decided that 20 to 50,000 deaths a year is all right. What might COVID look like as an endemic? And there's been a lot of hand-waving about this, oh, it's going to be this, oh, it's going to be that. There's a scientist in Seattle who's actually put a marker down for, here's my best guess. And the key factors are the natural transmissibility of the virus, the periodic waning of immunity, the mutation rate of the virus, and how many people die from an infection. I won't go through all his calculations, but his best guess is that we'll get annual endemic outbreaks involving 20 to 30% of the population infected, about 2 to 3 times influenza. Mostly pretty mild, but with enough infections, as Mark has showed you with Omicron, a small fraction of severe outcomes adds up. And he's guessing 40 to 100,000 deaths a year from COVID for, the next probably several years as it becomes endemic. And I think, we're going to have to decide as a society, is 40 to 100,000 deaths okay? If you add it on to influenza, is 60 to 150,000 deaths okay? What's our limit before we do annual vaccine campaigns and people start wearing masks during the winter? To be determined. My commentary on this is, it's probably going to be worse early and better late. It's probably going to be seasonal. Different years are probably going to have variable severity. As the population becomes increasingly immune from vaccination and previous infection, immune evasion is probably going to be one of the big drivers of viral evolution. And severity, don't assume that as the virus evolves, it's going to be more severe or less severe. That's not very well correlated with anything else. And the old tale that viruses become less severe, they adapt to the host, it's not good for them to kill the host, is actually not true. As long as the virus transmits effectively, it doesn't care whether you die after you've transmitted it to somebody else. So that's really not an evolutionary driving factor. Better therapeutics and vaccines are going to reduce the fatality rate. On the left or on the right is, the BA2 variant. You see the jump it's made from the BA1 or Omicron variant. The viral evolution is not necessarily going to be, a couple of amino acids at a time. So we really don't know what's in store from the viral mutation standpoint. And so that's where I come back to remember the difference between theory and practice. In theory, there's no difference between theory and practice. In practice, there can be a big difference. Social factors, are obviously big, and I have to say thus far, I'm not encouraged by our ability to handle new developments of this pandemic or future pandemics. If we critically look at all segments of what we've done, it's a little depressing. So to end, the good news is that we have a lot of tools now. Good quality masks are available. We understand about filtering the air, fresh air. We understand how to use precautions. We have vaccines that are still effective and will improve. We have better and better treatments. Testing is understood. You have to think of this as a multi-layer defense against the virus. And if you use these things correctly and consistently, you can really protect yourself. But if you say, well, I wear a mask except when I go out to dinner, that doesn't work. Of course, the other option is to just let nature take its course. I think, the dinosaurs and Neanderthals would say that, nature really resolves issues, but it's maybe not nice to be around when that's happening. And that's my point. We have all these tools. I'm very sad to see people not using them, because when you or your grandmother are in the ICU gasping for breath, it's too late. So I would just make the plea to do all these things. They cost very little, they're very safe, and they can be very effective if they're used properly. So I think it's question time. Back over to Mark.
Thank you, Dirk. That was excellent, as always. Kind of the whole point of why I wanted to focus on the UK was to talk about we have the tools, but we haven't been using them as well as we could have, and I hope that was helpful. I hope Dirk's very data-driven scientific approach to looking at all of this is very, very helpful for you. I go back to my Stockdale piece. I'm an optimist, but I'm a cautious optimist, and I am hopeful that Omicron has now provided a layer of immunity in the community, even for people who've not gotten vaccinated. But we would all be foolish to just assume that that is somehow a panacea. Obviously we've seen time and time again, that's kind of that Stockdale point, is that, we can't predict where things are going, and we know, as you've said, every pandemic ends, but it may be a while, and the virus will probably still be here at the end. But in terms of pandemic nature, but let's hope and pray, obviously, that a lot of this immunity that's come through with Omicron is helpful. But as we've shown, there's a lot of data behind boosting at this point, and there's a lot of data around testing. And if we can have rapid availability of that, if we can use common sense, I think we can do much better. So we have a lot of great questions from you all, and we're going to try and get through those as quickly as we can. The first one, Dirk, maybe you reiterate, this was a question about, is there going to be more of a pan vaccine coming out at this point? Is there anything promising you're seeing there? What do we see in terms of future vaccine development?
Yeah, the vaccines that Pfizer and Moderna have under development now are targeted to Omicron. They may be helpful for future variants, but they're definitely not a pan-coronavirus vaccine. There are pan vaccines in development which look promising, but they're a long ways from arriving at Walgreens or CVS.
So we got a question through the internet. Will this be a yearly vaccination for employees? I think by extension it's going to be a yearly vaccination for other people. What's your best bet at this point in time?
I kind of think yes, at least for the next several years. Maybe as we play whack-a-mole with different variants, and we have this background immunity in the population from infections. Gradually, the need to, we may kind of exhaust the virus's ability to mutate effectively. But I think for the next several years, we're looking at annual vaccinations.
So we got a question, I'll read it to you, that says, we're seeing interviews with reputable microbiology professors and doctors sharing concerns about the spike proteins in the vaccines, which could have long-term neurological consequences. Since you all have had the shots, I know I've had 3. Dirk, I think you've had more. Are you spending any time researching the long-term consequences of them? Well, let me say a couple comments. First is, prompted by this question, I went searching to try and figure out what you're referencing in terms of reputable microbiology professors and doctors. I couldn't really find that. I found some things with some people that I think are known to not be in what I would consider the reputable category. But let's just assume that maybe there is some risk, and I'll come back and say that I don't really believe there is, but let's just assume that there's a risk of the spike protein. Well, there's 2 ways to get the spike protein. One is through the vaccine, which provides you immunity. It's done in a controlled fashion. We've shown prevents mortality. The other way is to get infected, where you have a much higher risk of dying. It's an uncontrolled fashion. If you get a big dose of virus, you're going to have a massive amount of spike protein floating around. So the reality is everybody's going to get exposed to spike protein one way or the other. I mean, it's happened for the bulk of the population already. So I have a really hard time figuring out how some vaccine's going to be at higher risk, even if there were some sort of consequence like this. But the other reality is that spike protein, whether you were infected by the virus or whether you're vaccinated, it's gone from your system pretty fast. I mean, as Dirk showed you data, if you're infected, somewhere in that 5 to 10 day time period, most people clear the infection and whatever spike protein is gone. And similarly, when we look at the vaccine, you're basically manufacturing a little bit of spike protein real quick, your body reacts to it. So it's hard to see how a little bit of spike protein in either way is going to have some sort of long-term consequence. So we feel very confident in the safety. As Dirk has said, actually what we're even seeing is with repeated doses, the safety profile and the side effect profile is getting better and better and better as we look at each of these. I don't know if you have anything to add to that one, Dirk.
Well, first off, the CDC, the FDA, the Department of Defense, and the Department of Veterans Affairs all have databases on outcomes after vaccines from the point of view of safety. All that's really showed up of any consequence thus far is with the viral vector vaccines, some clotting disorders, and with the mRNA vaccines, some generally mild myocarditis in young men. Really nothing yet as long-term neurological consequences, and as Marc said, not sure what the mechanism would be. I just want to make a comment about these reputable microbiology professors and doctors, and I know this is a family show, so I won't give my unvarnished opinion about them. I think we have kind of three groups. One group are people who are knowledgeable and have specific concerns about vaccines or the way they've been rolled out, or the population that they've been applied to, or so forth. And I think, as we've always said, we're going to follow the data. In real time, the data is messy, and you're going to see Tony Fauci, you're going to see me and Marc. We're going to say one thing in August, and we're going to say, yeah, in November we know that what we said in August, it has an asterisk, or it was wrong, and we're going to try to correct that, and we're going to tell you what we know at the time. And there's certainly a group of very knowledgeable people doing that. There's another group of people who have reputations, and I'd say, there's Dr. Malone would be a good example of this. Did some excellent science. Kind of what I hear on the grapevine is that he's annoyed that he hasn't gotten as much publicity as some of the other people involved in vaccines, and so he's kind of gone off them and is now, become an anti-vaxxer. Very sad. And then there's a third group of people who wear white coats and have an MD or a DO or chiropractic degree after their name, and are basically going on YouTube trying to prey on gullible people to sell nutraceuticals and similar things.
As I've always said, I've said this for a year and 2/3 at least of this pandemic, science is messy in real time, especially when it's biological science. And there's absolutely nothing wrong with debate. In fact, that is part of the scientific process. But when debate becomes, I'm going to specifically find data to prove my point of view, or I go outside of that, that's where we see significant problem. And unfortunately, it's a small percentage, but it's a loud percentage. Very, very small percentage. But in today's day and age, it's pretty easy for somebody to become quite loud and spread a lot of disinformation. And it's a real shame because many people have died as a result of that. There's no doubt.
Yeah, and you've seen, the data changes. You saw that CDC data on prior infections. There's things that we don't know that we later learn. So it's very easy for people who have an agenda to cherry pick data and say, see, you really have to look at kind of the whole picture as it develops.
Yeah. So let me move on to another question. This is a question about risk of COVID and or vaccines. Somebody very specific, I don't know if there's a specific issue that somebody's getting at, but 85-year-old can they get ventricular fibrillation? This is when your heart basically stops and sort of wiggles around and you die. And that's the one that, one of the ones, but especially the one that you can shock people out of if you get to them quickly with a defibrillator. So can that happen from COVID? Can that happen from vaccines from somebody who has no prior history? It's anything's possible when you talk to COVID, for sure. I think an acute attack of COVID, if I had to kind of say, how would I get my brain to say, yeah, that happened, probably have to be somebody who had a significant case of myocarditis and inflammation of the heart that would have created that. We do know COVID causes myocarditis, and it does so at all age groups, and it does so at far higher rates than the vaccines. We also know that vaccines have caused some cases of myocarditis, especially and almost all in young men, but they've been essentially mild, and so we're not seeing that. And of course, that wouldn't describe an 85-year-old. So, I guess I say it's theoretically possible with COVID, but I wouldn't see that as very probable. I mean, the other possibility is somebody obviously with COVID who gets really, really, really sick and then along the way ends up with ventricular fibrillation as, a potentially fatal event as part of their hospital course as they get severely ill. Okay, so bunch of questions here about herd immunity. What is it? Is it even feasible? When we think about vaccines and other things here, what can we learn from polio in the past? Are we looking at COVID that'll look like polio? Will it be yearly shots? And again, are we reaching herd immunity? So let me cover herd immunity, and I'll ask Dirk to jump in as well. Pure herd immunity would be the idea that there's enough people with enough protection that some virus is going to peter out, basically, because there's no one to infect, or there's not enough people to kind of do the game of, I infected one and they infected one kind of thing. The higher the infectiousness of the virus, the harder that is to get to. And unfortunately, Omicron's now got an R naught, probably in the 12 range, which means if nothing else is going on, like you introduced Omicron to a naive population, I know there's a population that's never seen the virus, has no prior immunity, nothing, you're going to see every person spread to 12 people. I mean, it's as explosive as it gets. Really, the only virus that outdoes that right now that we know of is the measles. Thankfully, most people are immunized against the measles. But remember the Disneyland outbreak, where you had a bunch of kids together from some populations that were anti-vax and didn't get vaccinated, and it spread very quickly because it is incredibly infectious. So the bar is really high to get there. The reality is with this kind of R, it's going to look much more like measles over time or worse than it is going to get us to that pure herd immunity. Now, I can also define herd immunity as a point where we leave a pandemic phase and get more into an endemic phase. It's in the background, it's maybe seasonal, it may, this town may have a little outbreak, and then that town may have an outbreak at another different time, and you kind of wax and wane behind. That's certainly the hope with Omicron, that we've now gotten so many people vaccinated and then everybody else pretty much getting infected, and a lot of the vaccinated people getting infected on top, which probably has enhanced their immunity as well. But it's a hope. I mean, let's be real clear. This virus so far has mutated every time. So every time we hope that's where we're getting, we haven't. There's a certain part of me that kind of feels like God's been looking at us saying, I gave you technology and I gave you the smarts to create vaccines, and then when you didn't do it, I'm giving you Omicron to go infect the rest of you so we can get you some protection. But I'm not clear that that will ultimately be the final outcome. So we'll just have to watch where we look at that. When you ask about, polio vaccine, when you look at the durability of the vaccination, it's essentially lifelong. So I get a vaccine as a child and I have an immune response to polio for the rest of my life. Clearly, that's not the case with the flu. Clearly, that's not the case with COVID. And so the reality is I don't think we're going to see this look, anything like polio, most likely. All right, Dirk, lots of stuff on this slide, all for you. And it's all about antibody levels here. There's, how do they increase if you get Omicron? Kind of a little bit of what I just was talking about. Are the Omicron-derived antibodies going to lead to demise, ultimately, of the COVID disease? Some specifics about somebody who still had pretty high antibody tests, but their last booster was in September. Somebody who's been vaccinated and boosted, has been around a lot of people, wonders, hey, maybe I've had it, right? Now we see data that clearly says kind of, having both infection and being vaccinated, you're going to be even higher protected probably. Is there a way to check that? And second, another person asks the same thing and then also asks about titers. So maybe you could cover that broad band of questions there.
Yeah, I'll transition from the last one. I think the answer to will we ever have full herd immunity against COVID, the answer is no. If you look at the coronaviruses that are fully adapted to the human population, on average, you become susceptible to reinfection about every 3 years. So if COVID follows the same path, best case, 60% of the population is going to be immune at any one time. That's nowhere close to herd immunity. So I think for coronaviruses, the answer is no, never. So what about antibodies? So antibody titers is basically it's a measure of the level of antibodies in your blood. And the way they're measured is, they measure, pure serum, then they dilute it and measure it again, then they dilute it again and so forth. And that's where the word titer comes from. Antibody levels increase when you catch Omicron or Delta or any other variant. They decrease probably by a factor of 2, probably every month or 2. They're pretty much gone by probably 6 months or at some low plateau level. So it's very stereotyped. This is very normal. But they will not lead to the demise of the COVID disease. And we just had a question that came in, what makes a vaccine lifelong and another needed yearly? It's a combination of your memory B cells, your T cells, and how immutable the virus is. I'm not too familiar with the BAU measures, but I did check the Quest. I think this is the Quest Diagnostics test. I think 1860 is pretty high, pretty good protection. But that's, as I said, I'm not very familiar with Quest. If you had your booster in September and you still have a high antibody level, yes, it could be an indication you had COVID, but it could just be that your antibodies have not waned from your booster. Unfortunately, although we have a pretty good rule of thumb for a group of people as to what level of antibodies would provide different levels of protection against COVID, it's not confirmed, and it is absolutely not guaranteed to work in an individual person. So I think the answer to that so far is we're closer, but we're not there to learning what level of antibodies offers what level of protection against COVID. There is a test to find out if you had COVID, which is antibodies against the N protein, which is not, developed against vaccination, but I'm not really sure why you would want to do this other than just curiosity.
Yeah, but if you're curious, it is very doable, very orderable if your physician were to order that. Okay, so I'll cover this one because I've got it in green for Dirk, but really it was in my talk as well. And this was, if you got your second shot 11, 12 months ago, what's your situation and what's the effectiveness of the booster? You saw a lot of that data from me. If you're 11, 12 months out, you have significant waning immunity against Omicron, and your risk of getting infected with a breakthrough of Omicron is pretty high. You have some protection, but not dramatic. And actually, the protection level, if you remember, was getting down into the high 50s against hospitalization. So you've had waning immunity now. We can bump that back up to 90% with a booster. So get boosted, especially if you're this far out. But anybody really who's in that 5 to 6 month window or more needs to get boosted at this point if you want to have the full-fledged protection you could have. A couple more questions here, kind of in the similar vein with each other. I'm fully vaccinated. I got Delta before I was eligible for a booster. I've gotten the booster. So, you are somebody who's gotten a lot of layers of protection. I still think the rule applies in general, that we kind of see an infection as kind of like getting one shot. Clearly, it may have a broader immune response, maybe more durable. You saw some of the combination data. But I still urge my patients to continue going through with their vaccination series. So then you get to the how concerned should I be about Omicron. We will see some breakthrough infections even in that scenario. That's pretty clear with Omicron. You're going to be highly, highly protected against severe illness. So again, I go back to the what's your personal risk profile, what's your personal risk tolerance, make those good decisions, and I think you can live a pretty darn normal life, but be smart about those situations where you may be putting yourself at higher risk. I thankfully don't have huge risk. I ran the half marathon. I thought that was safe, but I can promise you when I was indoors with everybody gathering up for the race, I was in an N95 mask because there were a gajillion people there. Find those balancing acts to where you can have a normal life and you can actually do things that protect you as well. And that applies even more as we come down off this curve, which, I think by the time we get to March, based on everything we're seeing, we should be in a pretty good spot. But we don't know where the future will lead. We're still surging. It's the back end of a surge, but you see the hospitals are still busting full. We're still at 300% of previous levels. So caution level now should be higher than your caution level will probably be in 4 to 6 weeks. And it should be a lot higher than it was 2 months ago, for example. So again, use your common sense and sort of, modulate your behavior up and down based on your own personal risk and based on the situation on the ground at the present time, which is essentially the same thing we've talked about here. The question of why are vaccinated and boosted people still getting COVID-19, the bottom line is it's breaking through. I mean, if you look at, ultimately what we want out of vaccines would be preventing every infection, right? And we were really excited a year ago because that's the original data was that way, but we clearly saw it waned, and then we clearly saw the variant happened with Omicron that was able to really significantly break through, probably in large part because of kind of mass quantity that people are giving and a propensity to really strongly bind to your upper airways more than your lungs, which also may be why it's a little bit milder, but it's preventing what really matters. So, think about all the other coronaviruses that rotate that are out there, not SARS and MERS before, but all the seasonal ones. You never even know you had them most times. I mean, it's certainly not diagnostically. You might get sick, you might have a little cold. Hopefully we'll eventually get there with this one. We're not right now. But again, we're not as worried. I'd love to have it being protecting everybody, let me be clear, but it's not. We have to face that cold, hard fact right now. Some of that may very well have to do with the kinds of antibodies these generate. We're not necessarily generating tons of what's called IgA on your mucosal surfaces, which is where your first line of defense happens. So it sort of penetrates your first line of defense unless you're right after getting a shot. But then everything else kicks in and gets rid of the infection and prevents you from getting really sick if you've been vaccinated or if you have some natural immunity as well. Omicron, Dirk, I think I'm going to cut to the chase here because I'm watching the clock here. The Omicron variant actually provides pretty good immunity, it looks like, to all the other variants. In fact, one of the challenges we have is if you were infected with Delta, it doesn't look like you have that great immunity to Omicron, but if you were infected with Omicron, it looks like you have pretty good immunity, obviously, to Omicron and to Delta. Mm-hmm. Is that a fair statement?
Yep,
yeah.
Fair statement.
Okay, long haul. Let's talk about long haul. We know we've talked about that a lot with all the prior variants. It's obviously early to figure out long haul data on something that's just appeared the last 2 months, but what do we know so far?
Yeah, I think, sort of by definition, we don't know the answer to that because we haven't entered the long haul yet. But there's no reason to think that Omicron will be any different. And I think I actually threw in a slide on this. Maybe we could go to the next slide. Yeah, you did.
The next slide right here.
This is, follow up to, long COVID or post-acute COVID. Several articles that, if you're interested, you can read them. I mean, it's definitely a thing, even with asymptomatic disease. Vaccinated people are less likely to get long COVID, according to a preprint that just came out by about half. And for, if you want to do anecdotes and cherry-picked data like, the anti-vax community does, I'll throw one in there, which is, here's some observational biased data that shows that if you get vaccinated, your risk of dying from anything is about a third, from that of people who are not vaccinated. So if you don't want to die from anything, for the next 6 months, go get vaccinated. It's not only good for COVID, it's good for everything. And I say this tongue in cheek to show you how one data point, one publication, one observational study from the CDC, you have to interpret these things with caution.
Yeah. So we'll find out. We don't know.
We don't know.
I'm still in the category if I can avoid getting it, I'd like to avoid getting it. But we've all resigned ourselves to the fact that obviously it is highly infectious, and we are not going to have vaccines, at least for the foreseeable future right now, that's going to prevent every single infection out there. Specific question about asthma and allergy patients. Again, I'll try and keep things moving along here. Bottom line is that is a higher risk group. I wouldn't say it is the highest risk group we have seen. Certainly older smoker, emphysema types of respiratory issues, probably a bigger risk than a young person with asthma, but a young person with asthma is clearly at some higher risk than a young person who doesn't have asthma, but probably not the same higher risk we'd see with somebody who has a BMI of 40, for example, and is younger.
Fair. Not a biggie. Some studies show a little bit increased risk, but not a biggie. And I actually asked our head of pulmonary medicine yesterday, what's he seeing, and he said, really, it's not a big risk factor in his experience.
So now, Dirk, I'm going to actually ask, but we'll both talk about this some. What's our treatment protocol, right? We'd all love to obviously prevent severe illness and get people well more quickly with COVID. This is actually, unfortunately, one of the places where there's probably the most misinformation out there, the most abuse out there as well. We did also get a question coming through asking about hydroxychloroquine and ivermectin, which come up in some of this kind of preventive or early treatment kind of questions out there. So could you cover that, please?
Sure. I mean, as everybody I think knows from reading the newspaper, the problem here is supply of effective treatments. But monoclonal antibodies absolutely work, and there is one that is effective against Omicron. These new antivirals absolutely work, particularly the Pfizer drug. Very, good side effect profile, very effective. These things are typically reserved for people who have some kind of high risk, but I think as they become more available, as the experience with them grows, it's going to be basically recommended for everybody. Ivermectin, hydroxychloroquine, there's been a lot of research, a lot of it's, garbagey research. The results are, kind of clustering around no effect. Some find a small effect beneficial. Some find a small effect, not beneficial. Personally, I think I don't feel that they are effective. Most doctors and scientists feel they are not effective. But don't let the use of these unproven things dissuade you from also getting treated with stuff that we actually know works based on high quality evidence.
Yeah, and unfortunately, this is an area where there's a lot of misinformation. There's a lot of secondary gain that a lot of people have out there. There's a lot of people doing a lot of things to try to prompt their business, so to speak, of very unproven therapies. The good news is we have some very effective therapies. I mean, I think Paxlovid is an absolute potential game changer. So when I think forward to a few months from now, even if another variant comes out, and we think the next variant, every reason to believe that it won't evade a Paxlovid when you look at its mechanism of action. it drops hospitalizations by 90%. So if we could get the supply of that and get that to high-risk people, we can make a real dent in this, even as we have things moving around, even maybe as we have the next variant. The problem is supply. It's very, very limited. That's the topic of this next question here. The other problem with Paxlovid, just to be aware of, is it does have a long list of drug-drug interactions that doctors have to think about when they are prescribing it. Oftentimes those lists will shorten over time as we gain experience, but there is a long list. And the challenge we're seeing is oftentimes the highest risk people, of course, are more likely to be on lots of medicines, and then you run their med list and you sit there and say, nope, it's contraindicated here. So there will be some limitations. It's not a panacea, but it is a really great drug. The molnupiravir, which is the drug from Merck, probably not going to prove to be nearly as useful. It may be a kind of last effort when you have somebody who can't do the others, but I suspect we're not going to see it used in nearly the proportion that we see that.
Right, and remdesivir was just approved by the FDA. It's clunkier, obviously. You have to come in 3 days in a row to get an IV infusion, but it appears to be very effective.
Yeah, and that's the fundamental issue with that, is it's impractical for a very large population-based approach. So when you ask about our supply, this is all comes through the state from the feds. It's all allocated. The allocations statewide are far, far, far smaller than we would like to see. They are creeping up. We've been keeping up with demand on the monoclonal, which is sotrovimab, for a higher threshold, high-risk population than we were doing for the previous monoclonal antibodies that we were using, particularly Regeneron. Older population, highly immunocompromised, now getting that, but we have been doing that. We're hoping to get more. Most of the pills, because they are really outpatient therapies, are going to pharmacies. We get a smattering of the Pfizer Paxlovid, but we have situations, for example, let's say you have a person high risk, comes in, something unrelated, happens to have COVID, one of those incidental. Well, that patient is effectively an outpatient for COVID, but an inpatient for purposes of whatever they're there for. Some of them may qualify to use the Pfizer, so we may use in those kinds of situations. But for other inpatients, it's actually not part of the use case for those, so we have very little still of that. Okay, Dirk, family, mild symptoms during the holiday. Should they get antigen tested and quarantined if there's a close contact family member? What point should they do all that? Really, this gets down to quarantine and isolation.
This is like, when are you safe?
Right.
And I think it's, you are safe after you've been quarantined for 5 to 7 days and you have a negative antigen test. And, really you should never assume that you're safe. So if you get exposed again, you should quarantine and test again.
Great, and here's a specific question about somebody who's a senior, vaccinated, boosted, so they've done the things they can do. They have adult children, one's a teacher, so obviously somebody who's coming into contact with lots of children, depending on the age, perhaps a large group that aren't or can't be vaccinated, but both vaccinated individuals have had COVID previously. So everybody's got immunity. I'm going to come back to what I said before. You're going to modulate behavior based on your risk profile, and based on the situation on the ground, but certainly we've seen so many negatives of this pandemic in terms of socialization, in terms of family gatherings, in terms of everything else. So use common sense. But, I get together with my parents, all the time, and I don't see any reason why you wouldn't do that. Just think about who your bubble is, how broad it is, and if there are any situations where there's a doubt, where there's going to be really prolonged exposure, where you're worried about making someone sick, you can get a couple of tests now. They're more available than the little cartoon I had there now than they were a month ago, in part because the demand's come down again. But go get yourself some tests, and in situations like that, test. In the height of all of this, our whole family tested for our strategy for our holiday celebrations, and we knew we had that extra level of safety. We're going to wrap things up with just a couple more questions here. This one comes down to masks. Can you wash them, basically? And the short answer is no. You'll mess them up. Don't do that. If you're really short on masks, and you have an issue, you can put them in a clean, dry place for a number of days, and then probably reuse them for some period of time, not if they're soiled or damaged, but if they're just been used. But by and large, you cannot wash these or other things and count on them to help you. This is a question about if you've had a malignant cancer, are you in more danger contracting Omicron? You're probably in less danger than you would have been with Delta or a previous variant. But yes, if you have malignant cancer, and I'm not talking 5 years ago and you're considered cured, but if you've had cancer and you are a cancer patient, probably just the nature of having cancer, you may be somewhat immunocompromised, certainly from a treatment treatment realm and other things you may be. So you're definitely in a higher risk group as well. Omicron is now the only virus that's out there. There's as you may have seen, sort of a stealth Omicron. I think this is probably going to turn out to be just a lot of noise, a subvariant that's probably not dramatically different. But we're watching it because in a couple of countries it is starting to actually come up faster than the first Omicron, but we don't really know if that actually is having any different clinical outcomes or et cetera. So we're watching that closely. If I had to bet right now, it's not going to markedly change the game here. We have seen a few of those here at Houston Methodist. We got a question, Dirk, and we'd gotten an email from someone else earlier today. I read this. There's an editorial in the Wall Street Journal from a physician from Hopkins, Dr. Macari, who I've read a lot of his stuff. Basically, if I had to paraphrase the editorial, and they're asking about this, what's our take on it? He's criticizing the CDC for not talking enough about acquired immunity from an infection, and kind of some subtext is there's certain people who probably shouldn't get vaccinated, they should just get sick. I'd say some subtext is certainly in parts of the country you shouldn't have mandates in healthcare institutions. Love to hear your thoughts. I'll give you my thoughts on that.
Well, Dr. Macari would be in those three groups of doctors that I said. He would be in group one. Reputable guy who clearly knows what he's talking about, has a very, very distinctive and I would say occasionally extreme point of view on these things, and honestly I think does a service by probably being intentionally provocative so that we have these discussions and we consider things from every point of view. I certainly do not agree that just because somebody's had COVID in the past means they can't benefit from vaccination or boosting. And for occupations like obviously healthcare, but probably also like flight attendants and so forth, I think people who are in constant close contact with the public, personally I disagree that those people should not be boosted. I think that they should be boosted. The vaccines are very safe. They're very effective. Boosting is effective. And the argument that if we don't use them, they'll end up going to some underprivileged country. That's a specious argument, because if we don't use them, what's going to happen is they're going to sit in pharmacies and expire and get thrown away, realistically. I totally agree that the world has done a miserable job of vaccinating the world. And if you look at, Delta, which originated in India, which had, low rates of vaccination. Omicron, which originated in South Africa, which had low rates of vaccination. These are the places that, the variants are going to occur. So yeah, we should do that. But the idea that we should not boost people who are in high-risk occupations, I totally disagree with.
Yeah, and I'm with you on that. Particularly in healthcare, where we have a sacred obligation to do everything and to proactively do everything we possibly can to protect people. I think Dirk's shown you data and others. The vaccines are incredibly safe, and so if you've got prior infection and you get a booster, so you're that much more protected. You're protecting your patients that much more. Kind of the other subtext I get, and I mean, look, let me just say this. I have read most everything he puts out. I completely agree with how you categorize him in that kind of first group. And I have a colleague who always sends me the stuff and says, what do you think? And almost every time as I read it, I say, well, I agree with about 3/4 of it, and then it just goes a bit too far. Some of that's probably trying to sell some articles and trying to be provocative. Some of that's very useful when it's provocative, because scientific dialogue and discourse is obviously very productive. But there's a subtext in many of the writings that says, so your 20-something-year-old shouldn't get vaccinated. Well, it specifically looks in that case at, here's the risk for that 20-year-old, here's some potential, here's the benefit for that 20-year-old, here's some potential risks. I think overestimates the risks, but always when he writes, talks about kind of that 20-year-old as if he or she's sitting there in a bubble alone. And they're not. I mean, my 20-year-old interacts with, 4 80-something-year-old grandparents constantly. All my kids do. None of us are in a bubble. Every action we all take affects other people we care for, other people we love. We've seen that in our own data, as I just showed you today and talked about today, where the percentage of people getting admitted is going up basically because they're all older and sicker to begin with, and the young and the less careful have infected the people who've been more careful and are more at risk. And that's not I'm not indicting those individuals for doing that. I'm just saying that's the reality of some logical human behavior, that the more at risk we're hunkered down, the less at risk we're out and about. But we've shown a bad ability when clearly things move up to rapidly change our behaviors and nip them in the bud. And so we always get behind the 8 ball, and that's what we're seeing for and paying for. So I personally strongly disagree with sort of those assumptions as well.
Yeah, and you mentioned the 20-year-olds. I mean, we're doctors who are kind of dabbling in public health, and the first duty of a doctor is to their patient, their individual patient who's sitting in front of them right now. And yes, 20-year-olds are at pretty low risk of, hospitalization and death if they get COVID, but it's not zero. Many 20-year-olds in the United States have died. And I would just like Dr. McCary to have to sit in one of their hospital rooms as they're being intubated and say, I still believe they should not have gotten vaccinated.
So with that, I think we're going to wrap up. We did have one question about flu shots. I'll just quickly answer that. I don't have the exact answer off the top of my head, but it's in the 100+ million doses.
It's about 50% of the population,
yeah,
48 to 60%.
So you're about 140, 150
yeah.
million people, somewhere in that range. So a year ago, not quite a year ago, 8-9 months ago, we passed that in terms of the use of COVID vaccines. So we've ordered now many times as many COVID vaccines, certainly worldwide. So with that, I'm going to wrap things up. I want to thank everybody again for being with us. It's always a pleasure to see each of you, and we can't wait to see you next time. We're going to do some heart and some cardiac prevention and wellness, and I think you'll enjoy that. And I'm hoping and praying we'll do a lot less COVID that time. So thank you very much, and good to see each of you. See you next time. Thank you.